The next subset of agents that act at nucleic acids are the reactive species generators. And the first one that we had here was metronidazole. That's also given under the drug name Flagyl. And the mechanism of the reactive species generators is fairly conceptually simple. You give an agent that in itself isn't toxic, but inside the bacteria with bacterial-specific enzymes is oxidized into metabolites that are going to produce free radicals. In the case of metronidazole, those free radicals strongly impact DNA, and they can break down the DNA structure and fragment it. So the selective toxicity here is the conversion of metronidazole into the reactive species, which is more bacterially specific. So mechanisms of action, I want you to add to this that it creates reactive species and that fragments DNA, therefore blocking DNA replication and mRNA production. Metronidazole is fairly specific for gram-negative, and it has a really interesting effect with alcohol. If you remember back at the metabolism of alcohol, you have ethanol here. You break that down by alcohol dehydrogenase into acetaldehyde. Acetaldehyde is very toxic. Think of formaldehyde. You have to break that acetaldehyde down using the enzyme aldehyde dehydrogenase into acetate, which gets eliminated. Metronidazole has an effect of inhibiting aldehyde dehydrogenase, and this is unrelated to the reactive species generation. It just does this. So if you drink alcohol or have alcohol in the tissues that metronidazole is in, then you're going to make acetaldehyde. That's not going to be broken down, and you're going to have toxicity. Patients are told not to use alcohol within 3 days of taking metronidazole, and we don't just say drink alcohol, it says use alcohol, because even cologne and mouthwash, and now in COVID days, hand sanitizer, could cause this reaction. Metronidazole also has an intravaginal formulation, and that's used for bacterial vaginitis, so that the drug's given exactly where the infection is and can have a greater effect. Some specific adverse effects are that it can cause peripheral neuropathies and it can cause ototoxicity, so that can cause hearing damage. Contraindications include hypersensitivity or allergy to any other nitroimidazoles, and it's not given in the first semester of pregnancy. When you think about the mechanism of action that you're fragmenting DNA, you could immediately be concerned about whether it's going to fragment DNA in humans, because if it did, then it might increase mutations and might be carcinogenic. What they found is that it is carcinogenic in rodents, but when they looked at it in humans, we don't break it down the same way as rodents do. So evidence-based medicine, as we've used this drug, we haven't really seen evidence of carcinogenicity in humans. The medchem of that is very interesting. The second class of reactive species generators includes nitrofurantoin, or macrobid, or macrodantin. This acts very similar to metronidazole in that it's a prodrug or a drug that's not toxic. It goes into the bacteria. The bacteria have enzymes that transform it, creating reactive oxygen species. And in the case of nitrofurantoin, those seem to target the ribosomes. So adding to your molecular mechanism of action here, you're going to add that nitrofurantoin is going to be metabolized in bacteria to create reactive species, and those reactive metabolites are going to be damaging ribosomes. That's going to inhibit protein synthesis, and that's the mechanism of toxicity. So these are broad spectrum, and they're also used for urinary tract infections. Similar to metronidazole, where we said the drug itself isn't reactive, it has to be metabolized to create reactive species. They would both be considered prodrugs. They have to have bacterial enzymes to convert them. In this case, they are using nitroreductases. So nitrofurantoin here, using a bacterial nitroreductase, is turned into the nitrofuran radical ion, which then creates our reactive species. This is only being metabolized within the bacteria, so a large amount of the drug that's just been in our system is just going to be excreted as the prodrug. So that's excreted in urine and bile, and the urine can become brownish colored. Some contraindications for this are for any patient who has renal impairment, for anyone who has prior use of this drug and has had jaundice or hepatic dysfunction, and just like metronidazole, it's avoided in pregnant patients, although in this case, they've specified near or during labor and delivery or in neonates. So why it's not a concern in first or second trimester, I don't know the mechanism, but evidence-based medicine has shown that it doesn't really seem to be an issue. We said that this drug is excreted in large amounts in the urine, so that's a great drug for urinary tract infections. So our last class of antibiotics are the purine synthesis disruptors. And the purine that we're going to be looking at is folate. And the reason that's a good target for an antibiotic is that bacteria don't absorb folate. They have to make it themselves, whereas people absorb it dietarily. We don't have to make it. The folate synthesis disruptors include the sulfa drugs or sulfonamides and trimethoprim, which is given with sulfas. So first we're going to look at the synthesis of folate, in this case tetrahydrofolic acid. We're going to start with PABA, or para-aminobenzoic acid. That's converted by dihydroterate synthase into dihydrofolic acid, which is then converted by dihydrofolate reductase into tetrahydrofolic acid, which is one of the folates, so we're just going to call it folate. So you have to have these two enzyme steps in order to go from PABA to folate. The drug class here is the sulfonamides. We just call them the sulfas usually. There are several of them, but the most commonly used one now is sulfamethoxazole. The way that these work is that they're PABA analogs. So they look very similar to PABA structurally, and they're going to compete with PABA for the dihydroterate synthase enzyme. So they're coming in here, they're competing with PABA, and that's inhibiting the ability of dihydroterate synthase to convert PABA to dihydrofolic acid. So molecular mechanism of action, it's a PABA analog. It's going to inhibit dihydroterate synthase, and that is going to end up blocking folate synthesis. Without folate, you can't make purine bases, and without purine bases, you can't make DNA. So when we take a sulfonamide, it does look like PABA to our body, but because we're getting enough folate from our diet, that's us, then it doesn't matter to us that that synthesis pathway was disrupted. So sulfonamides are broad spectrum. They're both gram-positive and negative. They can cause photosensitivity, and like we talked about with the fluoroquinolones, they actually have both photoallergy and phototoxicity. So with the photoallergy, you're going to see a rash, and with the phototoxicity, you can see the sunburn if exposed to UV light. These also concentrate very highly in the urine. That's a good thing because any antibiotic that concentrates highly in the urine is going to be potentially effective against urinary tract infections. The negative part of it is if you get too high of a concentration. And sulfonamides, if too strongly concentrated, will actually crystallize out. And so you'll get these sharp little crystals that will end up cutting up the urinary tract. So that's called crystalluria, and you definitely do not want that. So one of the counseling points is to maintain adequate hydration, and that's the reason for that. That hydration is to prevent the sulfa concentration from becoming too high in the urine and prevent crystalluria. Some contraindications here are hepatic or renal damage. They're not given to infants under 4 weeks old. One very important thing to know about the sulfas are they are the most allergenic antibodies out there. So there are going to be a lot of people with sulfa allergies. That in itself, somewhat problematic because these are great antibiotics for urinary tract infections. But then it's more problematic because there are a lot of other non-antibiotic drug classes that have sulfonamide moieties. So any other drug with a sulfonamide structure is going to then also have a potential cross allergy. So anyone with an allergy against sulfamethoxazole, you have that concern they may have cross allergy with any other sulfonamide drugs. One important specific adverse effect of the sulfas is that they can be metabolized with glucose 6-phosphate dehydrogenase, and people of different genetic backgrounds have different alleles of G6PD. Some of them are more active and some of them are less active. And so people with less active alleles are referred to as G6PD enzyme deficient. Again, which alleles you have is completely genetic, and so some populations of ancestry have only high efficacy alleles, and some populations have low efficacy alleles. Of course, biogeneticists want to know why are these alleles different, and what they found out when they tracked the allele frequency was that the low activity alleles were basically along the areas that have the highest malaria risk. So they looked into those alleles and found out that low activity glucose 6-phosphate dehydrogenase was actually protective against malarial infection. Didn't need to know that, but I bet you're glad you do. And then the last drug that we're going to talk about is the last purine synthesis inhibitor, and that's trimethoprim. So when you look at the synthesis of folate here, we saw that you had PABA, that was converted to dihydrofolic acid by dihydroterate synthase, which was inhibited by sulfonamides. And then you had the second step, conversion to tetrahydrofolic acid by dihydrofolate reductase. And trimethoprim is going to come in here and it's going to inhibit that dihydrofolate reductase enzyme. So this blocks that dihydrofolate reductase. By doing so, it blocks folate synthesis and prevents purine-based production and blocks DNA synthesis. So the end result is the same as the sulfa drugs, but the place where it's acting is different. So if you give a sulfonamide and you block the production of dihydrofolic acid, and then you also give trimethoprim, then you block the production of tetrahydrofolic acid from any of the dihydrofolic that was made, then you're going to come out with an extremely strong reduction in folate. And so here we have a synergistic or multiplicative effect of these drugs. So trimethoprim itself, broad spectrum, it also can cause photosensitivity. Whether that's photoallergy or phototoxicity is hard to tell from the literature because often that's looked at while it's in combination with sulfas. And it also has high concentration in urine. The sulfa drugs also had high concentration in urine. So now we have two synergistic drugs that are concentrating in the urine. And that's going to be a great combination for treating urinary tract infections. So that's what you're normally going to see it for. The brand names are Bactrim or Septra, and they're going to be that combo of sulfamethoxazole and trimethoprim. And you got that right. Based on their high urine concentrations, these are going to be often used for UTIs. So we talked about the nucleic acid synthesis and activity disruptors. We talked about fluoroquinolones, and those blocked bacteria DNA gyrase, which was a topoisomerase. We had the reactive species generators, and those were prodrugs that got converted by bacterial-specific enzymes to create reactive oxygen species that in the case of metronidazole seemed to preferentially attack DNA, and in the case of nitrofurantoin seemed to preferentially attack ribosomes. And then our purine synthesis disruptors were both inhibiting folate synthesis. That was okay because we get our folate dietarily, bacteria need to make it, and because they both act at different steps in the folate pathway, they're going to act synergistically. So that's it. We're done with antibiotics. And now we'll move on to antivirals.